Go ahead, Dr. Mirzaians.
Yeah, I was just getting the screen ready. Hello, everyone. Thanks for joining me on this quick, hopefully, presentation on robotics. My name is Dr. Mirzaian. First and foremost, I want to thank the Society for inviting me to do this. This is a topic that I'm really passionate about ever since joining this group practice that I've been in. I'll give you a little bit more background on that. But I think it's a fascinating topic. It's the future of implant dentistry. It's the future of dentistry, I think, in general, as far as the application of technology goes. So let's jump into it and let's talk about it, utilization of robotics and dental implants. So a little bit about myself. I graduated from Midwestern University in 2010 from dental school out there in the Glendale, Arizona campus. Sorry, 2014. I did a one-year residency internship at LA County USC for oral and maxillofacial surgery, followed by a four-year residency at LA County USC Medical Center and Keck, along with Children's for my oral and maxillofacial surgery training. After I graduated, I kind of bounced around a little bit, did some itinerant work, did some group practice, but I've been in group practice since 2020 through various places, but I finally found kind of my last place over with the group at Advanced Dental Implants and Oral and Maxillofacial Surgery. We have 3 offices located in Westlake, Simi Valley, Glendale. Part of this wonderful team that you see up here with Dr. Sarkisian, Dr. Lytle, our boss and our head honcho, Dr. Nikchevich, Dr. Mike Newton, and myself. In about 2 years, we'll have 2 more guys joining us. So we'll be a full staff and we have a total of 3 offices, hopefully a couple more in the pipeline to expand. I became a diplomat of the board last year. It's a true honor and privilege to be among some of the best. And between the 2 offices and now a 3rd one since we acquired in this year, our practice has been in the community for a total of 47 years, mainly in the Westlake and Simi Valley location. I function through all 3 offices 5 days a week. If anyone needs to reach me by any point regarding anything, please feel free. My email is there. You can also reach out to Hosmi for my contact information, and our website is available for you guys if you need to review anything there. So what I wanted to talk about was robotic surgery. This isn't something new by any means within the field of medicine. Robotics has been around for a long time. I think most people would be most familiar with the Da Vinci system and its applications mainly in urology. It's applicable in many different fields, as you can see, ENT, abdominal, urology, all of them. And there's many different other systems that's also available to us, but there's nothing in the field of dentistry. And I don't think many people have even thought about how robotics can play a role in dentistry. At the end of the day, dentistry is considered surgery. We're cutting into the human body, we're performing something, and it's always subject to human error. And that's what robotic surgery tries to minimize. Aside from that, it tries to minimize the invasiveness of the surgery as it's done so in all these other fields. So it's nothing new to medicine, but it is new to dentistry. We're going to talk about the Yomi system. That's the name of the robot itself. It's part of a bigger umbrella company called Meiosis, and it's the first and only FDA cleared robotic system in dentistry right now. So to review just implant surgery as a whole, we have at our disposal right now 4 different systems of performing this surgery. Of course, the most conventional way is free-handed. That's what majority of us do every single day. We have static guides. That's the ones where you place the impression material, send it out to a lab, use a third party to program and place your implants, depth, height, all this stuff. And then they send you a guide in the mail. You go to surgery with that. And then we have our dynamic guided system. The dynamic guided system is your XNAV system. It's one where you can perform the surgery by having a CT scan and CT guided technology help you place that implant, but it's nothing more than that. It kind of guides you, but it's still in the drill bit is still in your hand. You're still dependent on the human hand and human error if anything should occur. And then finally, now we have robotic guided surgery. With robotic guided surgery, you eliminate a lot of these things. And we're going to talk about it in great detail as far as how this is beneficial. and with some of its pitfalls, because no system is perfect. So this is the Yomi system. This is what the robot itself looks like. You could see a dental chair there, just for kind of reference as how big this machine is. It's not massive, but it also doesn't fit in a very small operatory. So you need to have the space, and that's one of the things we'll talk about in this in the rest of this lecture. So one of the features of the robotic system, and one of the key things that the founder or the developer, inventor of this, Alain Meiosis, has wanted to implement is haptic feedback. So when you place an implant free-handed, everyone knows that you have a certain feel to things. When you place it, you know the bone is hard, you know the bone is soft. You can feel when you contact things, and that's something that's learned through repetition and training. So they wanted to actually give you that, and not just have this robot place this thing and you have absolutely no feedback. So they wanted us to be able to perform the surgery exactly as it's planned, and to have the feedback that we would normally have, and not to lose that in the surgery. And I think that's very important, and it's beneficial for the surgeon. So why Yomi? People use the XNAV system and say, well, we have that, why do you need a robotic system to do so? Well, with the Yomi system, you can do the dynamic system, meaning you can totally have the robot arm be free and not guide you at all, do everything off of the monitors. Or you can have the haptic feedback, where the implant drill is connected to the robot and it actually guides you to be where you want to be. What's interesting about this system is that you cannot deviate from the plan. Once the plan has been developed, and once you've positioned the implant, you're locked into that. Now, you could change that anytime throughout the placement of the implant. However, it won't allow you to deviate. If you make a mistake and try to push too hard, it won't allow you to go. That's the benefit of having the haptic feedback. In a dynamic mode, if you've used the XNAV system, that drill's in your hand. You can go straight through any part of the body. If you want at any angle, it won't stop you. But the robot has the ability to stop you from doing that. So a little bit about Meiosis as a company. They're a robotic company based out of Miami, founded by Alain Meiosis. He has a partner, and they're both engineers. Just a little bit of history. Meiosis is a son of an endodontist. He kind of started working with his father in developing some of this dental technology, and the machine is named Yomi after his dentist. Growing up, they became very good friends, and upon the invention of the product, he chose to name the unit after her. There's some big names behind this. We won't go into that, but in 2016, from a clinical study, Yomi became the first FDA cleared robot, which we already talked about for dental implant. Currently on the market, is the only one that's available, and it's advancing. Will there be others? I'm sure there will be. It's a very high. There's a very high barrier to entry in this thing, and you'll see why. The technology behind this is pretty advanced. So this is the robot. This is what we're looking at. We'll start in the top left and kind of move clockwise around. So you have your laptop. This is the laptop that essentially runs the machine, runs the machine software. It has a different computer built into the system itself, but the laptop allows you to do your surgical planning. So if you're used to creating guides of any sort for your patients in the static guides, this is the same exact software, except you're in control, that you have no one to talk to do it. Say, move this way, move it that way. You take your CT scan, you upload it into the system, and now you have restoration-based implant placement. You place your crown. Based off of that, you position the implants. You have the guidance arm. The guidance arm is the guts of the unit itself. So you can see it has 3 ball joints, and it functions along this. At the end of that guidance arm is your handpiece. Now that handpiece is locked into the unit. Again, this is held by the surgeon, and it's essentially guided by the surgeon. If you don't put input, it will not move. But when you put input, it will guide you in the direction that you have planned. So it will not move anywhere other than where you've planned, but it will only move if you push it in that direction. So you have to have surgeon input. It's not total hands off. Then we have the patient tracking arm. Now, the biggest problem in any form of robotic surgery has always been, especially when it's bone-based, is finding the patient in space, or tracking that patient in space. It's hard to have soft tissue landmarkers. I mean, you can't just put a couple points on the patient's head or cheek or anywhere else because soft tissue moves and that'll cause you to deviate from the plan. So you have to have a bony landmark. Now, you'll see coming up that we utilize a splint. A splint is placed into the patient's mouth. It's almost like a triple tray that you would use for an impression for crown and bridge. And then that remains in the patient's mouth throughout the entirety of the surgery. That tray, that triple tray, is attached to this tracking arm. And as the patient moves, the robot understands this motion and adjusts the robotic arm to move with it. And one of the videos coming up will demonstrate this, and it's quite fascinating. And then, of course, the monitor. This is a monitor that you use during surgery to visualize where you are, what you're doing, how far you are. Yomi can be incorporated into the digital workflow. As we talk about, restorative dentistry moving into a more digital, into a more, what's the word I'm looking for? Digital avenue, I guess. Everyone's looking to do things digitally and implement it, and that can be done with Yomi. So at the end of the case, we'll talk about how this is implemented into all-on-4 cases and digital planning, but you can use Yomi seamlessly in the digital planning stages, along with other people who are involved in the case, whether it be your prosthodontist, whether it be your general dentist, whoever it may be, using the crown down approach. And it's all collaborative and it's all in real time. So why robotic guidance for dental implants? So everyone has the challenge of, intraoral access being the #1 problem. In my personal opinion, at least that's what it is. So patients that can't open while you're trying to get into the back, you have a long drill, you can't fit it in there. They have TMJ issues, they can't open. Visibility, bone density, limitations of the human hand. These are all problems that every single experienced surgeon is challenged by. No one is immune to these things. Some of the limitations of the static guide can be delays from the scan or presentation of the patient to the time of actual implant placement. Patient comes with a broken number 9 and you need to replace it. Well, it's going to be hard to convince that patient to take an impression, send it off to a lab, wait for a splint, come back for precision placement. Now, some of us can't do this free-handedly and achieve ideal results, but there are cases where there's only one place that implant can go in an emergency case, and that's where the static guides are limited. And then I'm sure I'm not the only one in the room that has challenges with these intraoral splints. You have them made, they come in, you try to place them, something's not right. Now, where did that go wrong? Did that go wrong in the impression part? Did it go wrong during the scan? Is it the splint that's not seated? Is it the drill length? Everyone's had these where you take off the splint and then freehand 1 or 2 of any number of implants that you're trying to place. So those are the challenges that's overcome by robotics and dental implant surgery. So robotics really, again, fits in very well to the digital workflow. And one thing it offers that no one else can is flexibility within the surgical plan. If something doesn't look right to you, on spot, in that moment, you can stop, readjust the plan, robot's ready for the new plan. It's quick, simple, and reliable. My biggest thing that I use this for, other than our emergency implants that we place, is the flapless technology. So once I have this planned in our system, I no longer flap. I don't need to flap. I don't need to see the ridge for any reason. When I work with the drill, I can identify where it wants to go. And if I don't agree with it, then I step back, I take a look at the plan. And if I have to flap, I'll flap it. But I would say 95% of the time, I'm not flapping any of these cases. I may at most do a tissue punch and go straight to it. So here's kind of the workflow for Yomi. You place the splint. That's like your triple tray. With that, you scan the patient. Now, when the patient goes into your CT scanner, attached to that tray is a fiducial marker. In the presentation moving forward, you're gonna see that there's an external fiducial marker. It wraps around the patient kind of along the outside. This has now changed, and Yomi now has an intraoral. So it's much more compact, it's much more comfortable to wear during the case. I don't have a photo of that one, unfortunately, but I'll try to get it to you guys by the time we get to Las Vegas in case everyone wants to see it. Then once the scan is obtained with the fiducial marker, you virtually plan your case. That's positioning of your implant, X, Y, Z, whatever you need to do. Attach the patient to the actual machine via the tracking arm. You find your landmark. This one's critical because you need to verify that where the drill is actually where the computer recognizes it to be. For example, you'll see a video where we try to identify a marker. We can't. The computer and the CT scan are off somewhere. And you need to find something in the mouth that you can essentially pinpoint on the CT scan, so that now the two files are merged together. And then you perform your haptic surgery. Once your surgery is done, you remove the splint, patient's over. The whole surgery is over. So this is kind of what it looks like in the upper screen. There's a lot of scatter that makes it look a lot bulkier than it actually is. But this is the CT scanner. The green dots that you see is the extraoral fiducial array. So this is how it recognizes where the patient is in space based off of a fixed fiducial. Now you move into your restorative based planning. If you have a wax up in an STL file from a lab for any reason, or we have a surgical planning software that can do that for you, well, you can import that, such as CAD/CAM files, into the actual CT scan or the planning software. Once it's placed, then you move into the implant system and you start planning your implants. So let's take a look here. No one works this fast. It's all sped up so that we don't waste time, but this is kind of what we're looking at here. And there's your plan. So implant positioning, you can do this in 3 dimensions. Anyone who's done this in the static guides or used those third-party providers to do this, same thing, nothing different as far as the planning goes. So the implant can be done 2D, 3D, however it is that you're comfortable with. Obviously, you have the CT cuts in the top, and then in the 3-dimensional, you have your access point or your screw hole from the top, so you can visualize where it's going to be exiting from. So this is what we're talking about, the patient robotic arm. So this is kind of the guts of the unit in the sense of how it recognizes where the patient is in space. Now, if the patient turns its head to the right or left, the robot moves with it. So if you look at the drill that's connected to the patient, no one's touching that drill, but as you move the head moves with it. So the tracking arm So your tracking arm is connected to the patient. The drill is actually in the patient's mouth, but you can tell that this operator's hands are on the sides of the patient's head, rotating that head. And as he rotates that head, the implant moves with it. The drill moves with it. So you'll never have a situation where the patient moves its head and the drill doesn't. And that can cause injury, of course. So if you were to be in the patient's mouth and needed to change the plan for whatever reason, it all follows. There's no reset of any sort. You just continue where you took off from and where you stopped at. So once the patient is connected to the unit, you check your landmark. Your landmark is the identification that the drill recognizes that point and that the CT scan and the machine are in sync essentially. Normally we pick the incisal ledge of either 8 or 9 to get to it. If for whatever reason something is off, meaning you place the drill at the incisal ledge, but it's showing it way back somewhere in the molar region, well, then you can do this intraoperatively. You place the drill at the tip of number 8, and then you go back to the unit and say, that's the point, as opposed to first picking the point and then going to it with the drill. So the biggest thing with this one, as we said, is haptic feedback. With the guided systems or the dynamic systems, you can still drill, but you can't drill without some of the human error still in it. But the robotics locks you into your position and provides you the haptic feedback. So if you're going to go into soft bone, you feel a soft bone. If you're hitting something hard, you feel hitting something hard. If you're drilling and drilling and drilling and you think you're about to go through the lingual plate, because that's what it feels like, well, then it feels hard. You look on your monitor and you can tell exactly where your drill point is in space. One of the challenges that a lot of us have, especially talking about second molars, is kind of going into the patient's mouth and getting the drill oriented and standing it up straight in order to do it, just because of the limited access the patient has that far posteriorly. So the guiding system will orient the drill always to the long axis of the implant. So you can go in sideways and then correct for that laterally. So that gives you a little bit more space, a little bit of angulation to kind of play with, and allows you to use shorter drills. The biggest problem with static splints is that our drill lengths are excessively long and sometimes impossible to get back there, let alone rotate into the splint and then drop into the site. So with this technology, you can actually utilize a shorter drill and have much better access and visualization to the target location. Let's see here. So as you move into the site, into the patient's mouth, on the right side, if your drill is off, it'll first give you your angulation adjustment, meaning how far you are off the center axis of the implant. Once your angulation has been corrected, then it moves into the positioning. So whether you need to go lingual, buccal, mesial, distal, it will not go in any other direction other than that at that point, unless you switch the robotic system to what's called free mode, where it allows you to very freely move the implant drill anywhere you want it to be. But once you're in this guided mode, the drill system is locked and you can only move in the direction it wants you to move it. So your depth is controlled by your plan, as with static guides, where you have different key systems to lock you in so you don't get into the nerve, the sinus, or the floor of the nose, XYZ. The depth is controlled by the plan. If for whatever reason you're drilling and you want to go a little deeper, well, it won't let you. You can push as hard as you want. You'll break the arm before you actually go deeper into the patient's mouth. So if you want to, all you have to do is you can go into the system itself and adjust the depth of the implant and then resume surgery. Now it allows you to go deeper. You can rotate all the way around the implant, move it. You have total control over the entire handpiece as long as you are still within the confines of what you have planned, and it'll stop at the depth. So some key points for this software: the planning is very intuitive. If you've done anything with surgical planning, this thing is like second nature to you. And although this is robotic and you're locked into the plan, you always have total control of that handpiece. That handpiece will not move without your own input. So it needs something from you in order to do something. It will never operate on its own. It will never guide itself on its own. It's highly accurate to the sub-millimeter. The tolerance for error is under 0.1 millimeters as far as the unit goes. It allows for same-day surgery. So you are no longer hindered by timelines. So if a patient comes in, difficult case, you can do it right away. No longer need a surgical guide. Some of this got cut off. I'm not quite sure why, but future advances of this will be, we'll talk about in the end, but it will be making the tracking less bulky, and it will make the cost of the entire thing drop. So that's kind of where we're going with this. So the indications for use, you need to at least see the visual field. You need to at least be able to know where you're going so that you can actually place the surgical drill somewhat in the area to get it into place. You can feel the vibrations. Like I said, the haptic feedback is there. If for whatever reason you need to change implant styles, implant systems, implant brand, doesn't matter. If you want to go from a Straumann to a Nobel, from a Nobel to BioHorizon, if you want to go from BLX to from BL to BLX, you have free control, total control at any point in this entire surgery. If you're planning on placing, let's say we place a lot of Straumanns, replacing a BL implant, all of a sudden we don't have the stability that we want, well, then we just change the system right away to BLX. If you're doing this with a static guide, it'd be impossible. You cannot switch back and forth in the same system because of the planning that's gone into it. But with the robotic system, you can. So these are the systems that we use. Our two big ones are Straumann and Nobel. If you were to just take those two, which is the upper left, they have many different implants within the systems themselves. These are some of the lower ones are the Astras and the BioHorizons, and that's our surgical suite for the Yomi system on the right side. But the point is that even with two systems, within these two systems, you have 4 different levels of implants or types of implants, categories. And then within that, you have a bunch of different types of implants. And for each one of these, if you were to buy a surgical, if you're planning on placing these guided for any reason, and you need to buy their guided kits, well, then look at how many sets of drills that you would need. You need at least 9 sets of drills in order to make it happen for just 2 systems. But if you did it, if you could bypass the static guides, well, then you can use your standard kits for anything, and you don't need anything beyond that. Again, change drill lengths intraoperatively for whatever reason. If it doesn't fit, you can start with a shorter drill, at least get your mark down, and then proceed however else you need to. If it's a tight space, if you just want to have a punch location to at least give you a position of where you want to be, you can do it with that. So it's totally in your control. This is a big one, the emergency extraction implant temporization. We've all been there, crack number 9s, 8s, 7s, 10s, everything in the front, in the aesthetic zone. This really helps in some of those cases that have very limited bone, that you really only have one place to place that dental implant, because you can plan for it and you don't have to make the patient wait. So this is kind of what we're talking about, the extraction and emergency implant. Patient comes in, number 8, fractured, discolored, painful. You can take this tooth out, place the dental implant, temporize it all in the same time without having to rely on surgical guides, by knowing you have good bone, by knowing you have stability, and have a successful surgery with a very happy patient. This is another one. Patient came in after an injury, broken down 3 teeth, taken out, 3 implants placed. Patient goes home same day with implants. No longer have to wait for any type of healing to occur before you do that. So Yomi strengths immediately available, don't have to wait. Precision placement, again, we talked about sub-millimeter placement up to the levels of 0.1 millimeters. No longer need a splint fabrication, wide range of treatments. This goes kind of beyond the individual implant. We're now doing full arch treatments with this, and we'll see kind of how we're doing that. It's minimally invasive, as robotics has proven to be in medicine. You don't need to create flaps. If your surgery calls for it, then you must. But for your single or 2 or 3 individual implants, no longer need to create any massive flaps in order to visualize the area. It is a revenue stream. It is cutting edge. It does add to your practice's strengths as far as being an advanced technological office. Less implant systems to worry about, less components to worry about. You don't need to buy so many drills, so many splints, X, Y, Z. So it's a great system, but it has some shortcomings. It's definitely more time consuming. If you know anyone in the medical field that's used robotics, the nurses always tell you how difficult it is to set up these cases. The robot does take time to set up, to calibrate, to get it ready. There is a per implant cost. The splints themselves run about $150 a splint, and you cannot reuse the splint. So every time you use it, you have to eat the cost of $150, or the triple tray, the splint that I was talking about. And then the staff needs to be well trained. This only works if you're not the one controlling the system itself. You need to have your nurses there being able to switch back and forth, telling the implant, now we're at the second drill, now we're at the third drill, and being able to walk you through it without you having to deglove or reach over every time. It also slows you down. Although this is precision placement, it does take time. I can place a single tooth implant a lot faster freehand than I can with this, but if it's a case that really needs specific placement, then this is the only way to do it. The dislodgement of the stent is an issue with this system. A lot of people come down with worn down teeth. They don't have longer teeth in the posterior. They have a collapsed posterior, or they have large tori or large alveolar ridge. The splint attaches to the patient by way of impression material, and it's tightened down with a screw that kind of grips it. Now, if you have short teeth and you don't have a lot of interdental spaces for it to latch onto, then that splint can become dislodged, and now your surgical planning can be off. And again, this unit takes up space. As we saw in the beginning, compared to that dental chair, it takes up a lot of room. You throw in 3 more people in there, so someone on the computer, yourself behind the robot, and one person switching out your drills. You need space for this unit to be in there, as small as it actually is compared to other robots that are available. So we're going to talk about 4 cases that I'm going to present on, and all of them required some form of grafting that we used. These are just some of the guidelines that myself and some of my partners use, whether it be 2-stage, the bone ring. The bone ring is Strauman's system, where it's cadaveric bone, the implant's placed within the bone ring, and then the bone ring is placed. That's a topic for a different day. Osteotome, osteodensification, that's your VersaBurst system, and then of course just having crazy amounts of bone or not having to graft at all. So here's RI. He came in for tooth number 2, was extracted 9 months prior due to some fracture. For this case, we use a punch technique, Yomi guided surgery, and a little bit of osteotome crestal elevation with some Krios and 12 weeks total healing time. So this is the patient. On the upper left side is what the tooth looked like at the time of extraction, and then on the lower left is at the time of implant placement 9 months later. So short crestal bone, sinuses there. He already had tooth number 3 placed by someone else outside. Use the osteotome technique. Again, you need at least 6 to 8 millimeters of good quality bone for this area. We use the Yomi system to initially get our location. And again, being a number 2 site, it's difficult to get back there. So we use our shorter drills. And when you plan for this case, you don't plan for the actual implant. So this is how the robot can guide you to do something other than implants. It will guide you to the depth of your first drill, which will be just short of the sinus. And that's where you'll set it. You'll pack your bone, you'll do your osteotomes, you'll pack your bone, you'll get it up there. Then you go back into the system for the Yomi system and place your actual implant into the sinus. And then that will allow you to take your drill to depth. So if we were to plan it this way, we plan it as if we're going to go into the sinus because the graft has already been done at this point. And then post-op, that's what it looks like. So RR, tooth number 14, again, extracted due to fracture, 7 months healing afterwards due to patient delay. Excuse me. Punch technique was used again. You don't need to create flaps for this system. You go straight in with your first drill. Yomi guided places, and we use osteodensification burrs, the VersaBurst, in order to compact some bone. And then we have 12 weeks healing afterwards. So this is the VersaBurst system that we're using in our office. So missing number 14, short crestal ridge height, sinuses look clear. So for this case, you actually plan for the implant depth because you're taking your densification burst to depth. You're actually planning it, but you're planning it in stages. So you take your first, you position your implant initially just to the floor of the sinus for your first drill. The robot will stop you there. It won't allow you to go further. Once you switch out your drills, then you increase the depth, meaning you place your implant further into the sinus, and now it allows you to actually compact your bone, go in and out as you need to create that densification. So this is the system where it's guided, and then finally the implant placement. So tooth number 14, CN, patient CN, again, extracted due to periodontal involvement, lateral sinus lift, using various techniques, and then finally Yomi placement, and then sent for restoration. So extremely short height, sinus lift is done first, then the implant is placed. And you don't need to scan these patients again, as long as you kind of know where you want to place them, you can do them ahead of, you can do the sinus lift and the placement simultaneously. And there's post-op. So here's an image of what the old fiducial marker looks like. So in the all-on-4 cases, obviously you're going to be losing all the teeth that are involved. So you need something else to anchor, and you're anchoring to bone. In this case, the splint is actually screwed into the maxilla or the mandible preoperatively. The patient is scanned. This black thing you see is the external or extraoral fiducial marker. Those silver things are the beads that were the green points that we saw in the initial slide. However, this is now changed to an intraoral. It's much less bulkier. It extends into the mouth, and it's much more comfortable for the patient to wear. But this is, again, only done for the scanning portion of things. This is kind of where we were at the end of the surgery. The system can also be used for trefoil. Trefoil's somewhat popular. It's Nobel's essentially smile in a box. It's a prefabricated bar used for restoring the mandible in a quote-unquote all-on-4 technique, but in this case it's 3. It's a prefab bar, but the most critical point to this system is placement of that center implant, because this controls the angulation of the prefabricated bar. If this center implant is off by even 1/10 of a millimeter, the bar will not fit. So this procedure, from the time you start drilling to the time you're done, is about 15 minutes, but the placement of that very first implant takes like 30 minutes because you have to look at it so many times to make sure it's accurate. And Yomi can help you place that very accurately. And you no longer have to worry about angulations being off with this system. So this is the trefoil system for this patient. Patient comes in, obviously dentition is failing. You attach the patient, as you can see on the upper left-hand side. Those little circle dots floating in air are your fiducial markers. This is a bone splint, meaning it's screwed into the mandible itself. It cannot be attached to soft tissue because of the mobility of soft tissues. Plan for the implant placement and placement. So you can perform these surgeries off-handed. If you're left-handed, you can do it right-handed. If you're right-handed, you can do it left-handed. Because the implant guides you, all you need to do is provide input. As long as you provide that input, the robot will move. If you don't, it will not. You no longer need to invest in 3D printers for the sake of splint fabrication. So if you have one in your office where you're using it to fabricate splints, although it does take some time, you no longer need to do that because the splint is now obsolete in this scenario. And it's as close as you're going to get to doing standard surgery with any type of technological input. So really, if you ever get a chance to try the system, and if you want to come to our office and see it, you're more than welcome to. There's great feedback, and that feedback is truly something that's unique about this system that makes it great. So here's one in real time of our partner doing it. One of the challenges is there's not enough space to record anything. So every time I ask my nurses to do it, they don't quite get the pictures that I want. But here's one with my partner doing placement of teeth 7 and 10. Patient came in with a failing bridge that was 7, 8, 9, and 10. Teeth that were in place were 7, 8, and 10. We removed the bridge, and we were planning for robotic placement of the implant. So here's what you initially start to do. The patient is scanned. Excuse me. The patient is scanned, and the beads right there are now the intraoral beads. These are your fiducial markers that help locate the patient in space. You adjust the occlusal plane. Once the occlusal plane is adjusted, you create your spline contours. This is essentially what we do for our CT scanners. You pick your landmark. Now, one thing that's critical here is we wanted a landmark on number 11, but every time we would place it there, the landmark would be off. Anyway, we'll skip that. But every time you would place the landmark on number 11, it would put it somewhere else. So this is a scenario where we had to first put the drill where we wanted it to be, which is on the cusp tip of number 11, and then tell the machine this is where it is, so it can merge the two files. Every implant system known to man is available within the Yomi system. You can do for number 7 a Straumann, you can do for number 10 a Nobel. If you're intra-op, I've done this before, where you're starting with a Straumann and then you realize after the first drill that, oh, my referral likes Nobels, I had to switch right away. I was able to do that. No harm, no foul. So here's surgical planning. The implants are placed arbitrarily initially, and then you can select individually the implants and where you want to place them. You can spin it all the way around, go all the way around an implant 360 degrees, make sure fully encased in bone. So this is the attachment of the, I skip past the rest of it because it's all the same, but you get the point of you're able to place the implant exactly where you want it to be in space. So this is the attachment of the patient tracking arm. Here you are, you attach the actual unit to the splint itself. If this patient were to move their head right now, the entire robotic arm up top will move with it. And this is actual surgery occurring. Angulation correction, as we talked about, now mesial distal or palatal lingual. Now he's locked on, ready to go. In the upper left, you can see the location of the proposed implant. You see the tip of the drill itself, both within the CT scan and in the computer animation there, showing you going to depth. So here you are, placing the implant at number 10. And again, you have real-time feedback. You can feel as it's getting tight, you can feel the Newton centimeters as you're putting it in, if that's something you're accustomed to feeling. Now you know you're at depth, and you move the unit out. So after placing number 10, move on to number 7. This is good angulation showing the drilling again. So as you can see, there is a very knowledgeable operator on the left-hand side controlling the unit, switching you back and forth between your implant drills, when you're going to implant, when you're going to your next drill, or using a short drill, long drill, all that. You have an assistant to your right-hand side, and then of course yourself doing the surgery. And that's the presentation. A couple things that I did want to mention. the future of this technology is not what it is today. Now, there's a lot of components that are going into this right now, such as the tracking arm, such as the fiducial marker. We're at a point now with this technology where you no longer need a preoperative scan with a fiducial marker, meaning you attach the splint to the patient. You have a preoperative scan from before you even started the case. You move the patient over to the surgical suite, you connect it to the tracking arm, and now you have what's called Yomi Go, where you essentially hover the implant to where you think you want it to be, and you say, this is where I want it, and it drops the implant in that location, and that's how you control depth. You no longer need to take another scan with a fiducial marker. Where this is going is eventually being able to fully eliminate any scan of any kind, meaning with a tracking of any sort. So what we want to do is have a trackless system with a preoperative scan, meaning you go into the patient's mouth, you tap on 3 points, it tripods the scan to the it recognizes the 3 points in space relative to the CT scan. Those units are merged, and then your implant's done haptically. This technology is pretty new, but it's moving pretty quickly, and eventually we'll get to where the Da Vinci systems are, where you're not really hands-on, but you're placing these things at a distance, doing robotic technology, and this can be utilized worldwide. So thank you for your time. And if there's any questions, I'd be happy to answer them via email. If anyone ever wants to stop by the office and see this technology, our doors are always open to you. And I look forward to seeing you in Vegas.